expectancy and all of the countries hardest hit by the epidemic. And this had a huge economic consequences to that country. Teachers were dying, physicians were dying, nurses were dying. The very economic energy of the country and the fabric of societies were being threatened. And through PEPFAR and the Global Fund, we've actually seen a reversal of all of these declines in life expectancy. And so it's a very exciting time for all of us to be able to really finish the fight that we started those years ago. You've seen all of these from Dr. Fauci, and I learned when he was my attending not to repeat his brilliance. So I'm moving on to just show you that the performance is not equal in every country. And if I leave you with two messages I wanted to leave you with, PEPFAR represents the absolutely best of America. It represents a program that had its nidus in the Life Initiative under President Clinton, a brilliant bill written by Senator Frisk and Senator Kerry at the time, which then it was translated and became President Bush's signature initiative, PEPFAR. But what was started by President Bush was expanded to an amazing program under President Obama. And we know that Secretary Kerry is deeply devoted to this program. In addition, it's been reauthorized twice in total bipartisan support, including most recently in November, where some people would question the bipartisan nature of our Congress at the time, but strongly endorsed this program. In fact, are so involved with this program, tell us how to do it better each time the reauthorization comes. And that's a very exciting thing, to have members of Congress interested enough in your program to write legislation to make your program better. So it's an exciting program to be able to work on. So it's really the best of what we bring to the table as Americans, a translation of our tax dollars through science into humanitarian programming. But the response to this epidemic is not equal in all countries, and we still have this volume of work to be done. And so this shows a model of incidence in the last report from UNAIDS. You will see lots of UNAIDS data. Please go to their AIDS Info site. It's an amazing site. I'm constantly there pulling down their data. But some countries actually had a reversal of gains, and we all know this in Uganda. I like to do these country comparisons because people often ask me, do we know that we're really making an impact? And we have lots of studies out there right now, started by Ambassador Gooseby, looking at combination prevention that will give us definitive answers. But what can we say now, and what can we learn by the data that we have now, and how can we analyze it to really see if there's a difference in countries? Well, this is two countries. This is Malawi and Mozambique. I picked these two countries because they both have a similar HIV-1 subtype called C. They have similar host genetics, so we know that there's the same virus in both countries, similar host genetics in both countries, yet the country profiles of new infections and deaths are very different, and hopefully you can see that the magnitude of the epidemic was very similar in both countries, but yet we have Rwanda with a dramatic decline in incidence and death, and a less dramatic decline in Mozambique. Well, if you start to dissect that and you look carefully at what is the difference in those countries, you can see the difference of coverage of life-saving services, whether it be PMTCT or adult care and treatment, pediatric care and treatment, is dramatically different. And the speed of coverage in Malawi was very different than Mozambique. So this starts to give us some insights. So then if we look at two additional countries, let's look at East Africa, a very different epidemic, a very different HIV-1 subtype, a very different host genetics. Yet you see two countries, Kenya and Uganda, and then you can see, that's okay, go here. Kenya and Uganda, we see very different profiles. And we're very concerned about Uganda, who had this spike in new incident infections at a time when Kenya, a country next door, was having a significant decline. Again, what are the differences in the countries? The difference was the speed of scale-up of the life-saving services between Kenya and Uganda. In addition, Kenya had expansion of its circumcision rates and voluntary medical male circumcision. It was one of the studies that Dr. Fauci mentioned that was great science that got translated into high implementation of that service immediately as compared to other countries have delayed. So let's look a little bit about trends in treatment coverage. So this look is at PMTCT coverage, and you can see again, there's very vast differences between countries. Dissecting documenting the differences between the countries, understanding those differences between the countries, and correcting those differences so all can scale at the same speed. It has led to these historic declines, and I want to just mention this because this is where political will and leadership becomes extraordinarily important. Michelle Sidibe didn't talk about it, but he was a leader in this virtual elimination of pediatric HIV with an announcement with Ambassador Gooseby to really focus on getting PMTC coverage up to a level and dramatically reducing the number of newborns born with HIV. And you can see in the last 3 years, since that announcement, they've made more progress than they had in any of the 6 years previously. Do not underestimate the importance of focus and political will in bringing us together to really make a dramatic change. The exciting thing about Malawi, again, that I just wanted to mention, is get the data to see if you have unexpected results. So this is looking at, they rolled out what we call B+. That is ART, full combination ART, full effective ART for the moms, pregnant moms, independent of their CD4 subcount. And at the time, they were measuring the return rate of under 2-month-old infants and 2 to 24-month-old infants. And the astounding thing that they realized is when they provided care for the moms brought their babies back. And these newborns, independent of whether they had HIV or not, received comprehensive newborn care because their mothers were bringing them back. So when mothers feel like they're being cared for, and mothers feel like the clinic wants to see them and care for their health and keep them healthy so they can care for their children, they bring their children back at astounding rates. And it wasn't just the newborns, they brought their under 2-year-olds back too. So it's very important as we look at these programs that we collect the data that actually allows us to see these new things and the impact these programs are having beyond their specific intent. We look at ART coverage, we see the same things. There are countries that have dramatic increases in their ART coverage for adults and those who are lagging. I just want to go through some quick examples of countries that have excellent data because they've done every 4-year or every 3-year surveys on HIV prevalence. And one of these countries is Botswana. But you can see, and it's shown here in the different colored lines, and the dark blue line is the most recent prevalence, which shows a dramatic climb in prevalence in all age groups, except for the oldest age groups, which would be those people who are taking ART and aging up, because these studies are done 4 and 5 years apart. So this is beginning to show that as you have this degree of decline in prevalence in all of these different age groups, you have to have declines in incidence. Next door, however, we have Swaziland. And there was an excellent study done by ICAP in Swaziland looking at incidence. And the interesting thing is 53% of women had CD4 cell counts that were greater than 500. This means that there's a large number of new infections still occurring in women that are not being contained by our current programming in the country. In contrast, if you look at a similar study done in Kenya, less than a third of the women have CD4s over 500. Again, showing early differences in countries and degrees of incidence. And that country that I just referred to is Kenya, and they just completed their second AIDS indicator survey. And you can see, I just want to highlight a couple of things. Prevalence down in both men and women, prevalence down in urban and rural areas, and this is the comparator line showing the blue line, significant declines in prevalence at all age groups. This is a very important piece to Kenya, and if you can see on this slide, 80% of women now know their HIV status and have been tested. This is phenomenal. You talked about the United States. We were talking about getting to 82%. That was after years of focus. Just after less than a decade of PEPFAR and Global Fund, 80% of the women have been tested. And you can see we still have a gap with men, but it's up to 63%. But this is again the story of the importance of circumcision. You see still a significant HIV prevalence of 16.9 in the red line. Again, in this most recent survey, HIV positives and uncircumcised males, showing that we still have work to do to ensure that we have voluntary male circumcisions in all countries where it makes sense. Finally, I'd like to talk a little bit about the demonstration of viral suppression at the community level. You saw that cascade. This was a door-to-door survey, 16 to 20,000 participants in Kenya. Of those who were on ART at the community level, not at the clinic level, but at the community level, all personnel, 78% viral suppression. That's an enormous number for all of us and gives us great hope. This is individuals who may have been just placed on ART a week ago, or may have been placed on ART 10 years ago. Viral suppression of 78%. And of those who were not suppressed, again, the 78% is shown in the light blue. A significant number of the patients had under 50,000 copies. Again, very encouraging that all of us, these programs are not only having impact, that they're having sustained impact, and most importantly, our patients every day are making the decision to get up and take their pills even though they feel well. And this kind of relationship needs to continue. And as we talked about the community health workers and the communities and the importance of that patient feeling like it's important for them to continue their medication. John Stover now has modeled Kenya and looked carefully at the impact of ART on the decline in incidence, and he in his analysis found that over 50% of the decline in incidence can be directly linked to the ART provision and program. So this is an exciting time for us, and I think I've been to many talks where Dr. Fauci says we have the tools, and we should have the will, and we can do it today. And I think that's the challenge to all of us. And I just wanted to conclude with demonstrating that progress is not equal in all countries. We still have burdens of disease that have to be addressed. And then we have some scientific questions that we need to answer and some remodeling. This is deaths among HIV populations in sub-Saharan Africa. The good news is, the orange line is what we have held the number of non-HIV deaths constant since the beginning of our modeling. We know now that people are getting to be my age, and maybe some of us in the front row's age, and they have other non-communicable diseases, and we need to look carefully at our models to make sure that we really have the right rates of each of these measured. But this is, again, an excellent UNAIDS graphic which shows young women, as this was mentioned again by Michelle Sidibe, young women are still at enormous risk. This is comparing young women in a whole series of countries across sub-Saharan Africa compared to men and armed. Women have 2 and 3 and 4 times the risk of infection with HIV. These graphics look at the burden of disease. You can see that South Africa, this is number of people living with HIV. The large wedge is still South Africa, but you can see that Nigeria is gaining on South Africa in burden of disease, and I think this is disappointing to all of us that Nigeria's diseases keep expanding. And this is new adult infections, and you can see the Nigeria wedge is even getting larger. But this is a very telling wedge, and this shows that the new pediatric infections are occurring at a rate of 2 and 3 times any other country in Nigeria compared to South Africa and other countries that have made tremendous progress. So I just want to conclude with where we are going at amfAR. And we have been put on an amazing trajectory by Ambassador Gooseby. We have the blueprint released by Secretary Clinton, and we have an excellent roadmap of how we should go forward. On top of that roadmap towards the AIDS regeneration, we are adding an impact agenda item that really will help us define what countries can we really show that we are getting under what we like to refer to as R1, and epidemiologic control of HIV/AIDS, where we can help and work with countries to predict when they will be able to actually reduce budgets to HIV/AIDS because the epidemic is so well controlled. Many of you in this room have called for an increased transparency agenda and an increased availability of all of our information and data, and we're working on that very carefully now so that others can be looking at our data and give us insights into our work, and an accountability agenda that expands our cost efficiency and cost effectiveness agenda along with performance of all of our partners. And so this is a line listing of our priorities. Our most important agenda is efficient and effective control of this epidemic, and increased fiscal and programmatic oversight to ensure that every US dollar from the people of Kansas and Iowa, from the people of California, Pennsylvania, to ensure that their dollars have the biggest impact they could in every country that they're invested. Greater transparency, as I mentioned, in-depth, more in-depth country analysis so we can look at progress not only at the country level but subnational level and at the site level. Increasing the health diplomacy potential of the State Department. The State Department has amazing people in different bureaus and sections devoted every day to improving the health and welfare of individuals around the world. We have added a very strong pillar. It was a transparency pillar, and it was similar transparency, and it was human rights through all of our programming. But due to the recent issues that have occurred in our programming in a series of countries and our depth of our concern about the level of stigma and discrimination that is advancing across sub-Saharan Africa and could impact every one of our programs and every person. If people do not feel safe, it doesn't matter if they're LGBT or not. If people do not feel safe, and you don't feel safe if one group is targeted. If people don't feel safe, they will not access services, they will not be seen in public clinics, and they will not receive health care. Like many of you in the audience, I lived through that time of stigma and discrimination in the United States. It was not so long ago. I was active duty military, and MSN behavior was prohibited in the military. It was before Don't Ask, Don't Tell. It was a difficult time. We had patients at risk every day. But we found a way to care for our patients and to make them feel safe as clinicians. And we, and those of us in the room and around the world today, have to individually find a way to make all of our patients feel safe and have access to life-saving health care.